will go to the next one. It's from Dr. Attila again, Dr. Attila Kovacs, and he will talk about the role of electrochemotherapy in the treatment of soft tissue tumors.
Thank you very much for the invitation. It's a great pleasure to give you this talk on electrochemotherapy in the treatment of soft tissue tumors. These are my disclosures. Soft tissue tumors are a diverse family of malign and benign tumors, and the categorization continues to evolve as more insight is gained into subtleties of their patterns of differentiation. As such, the classification of these neoplasms is an increasingly complex subject that requires basic understanding of the biochemical attributes of the lesion. The imaging of soft tissue tumors consists predominantly magnetic resonance imaging with special characteristics of the SCTs. Most SCTs are hyper-intense on T1 imaging and hyper-intense on T2 weighted imaging and show enhancement on a post-contrast T1 weighted imaging. In most cases, MRI cannot provide a specific diagnosis except for a few soft tissue tumors like hemangioma, lipoma, or fibroma. And in almost all other cases, biopsy of the soft tissue tumors is required for the definitive diagnosis. Also, MRI cannot reliably differentiate between benign and malign soft tissue tumors. In general, a malignant soft tissue tumor tends to be larger in size, and despite increased blood supply, it quickly outgrows it. Thus, a large malignant tumor often contains areas of necrosis, which impart a non-homogeneous appearance on T2 weighted imaging, STIR, and post-contrast T1 weighted imaging. The characteristics of soft tissue tumors in MRI are variable. Only approximately 5% of the benign STTs are larger than 5 centimeters in diameter, and most tend to be homogeneously hyperintense on T2 weighted imaging and STIR, with homogeneous enhancement on post-contrast T1 imaging. Also, a superficial soft tissue tumor is usually benign, whereas a deep-seated tumor tends to be malign. However, a small size or superficial location of a soft tissue tumor does not always indicate that it is benign. Similarly, peritumoral soft tissue edema can be seen both with benign and malignant soft tissue tumors. As a rule, a malignant soft tissue tumor tends to be hypervascular with increased perfusion, but even use of intravenous gadolinium cannot always differentiate a benign from a malignant soft tissue tumor. SDS, soft tissue sarcomas, are rare and heterogeneous, with a variety of subtypes having a different prognostic. As up to 85% of gastrointestinal stroma tumors with KIT mutation respond well to targeted imatinib therapy. SDTs generally have a poor response to systemic therapies. Surgery is the mainstay of sarcoma treatment. Resection objective is a R0 because quality of surgical margin impact local tumor control and survival. Therefore, resection can be large. Radiotherapy is possible in neoadjuvant and adjuvant treatment to improve local tumor control, and improved LTC is linked to a postoperative radiotherapy. Percutaneous core needle biopsies are commonly used for diagnosis confirmation, and local ablative therapies provide a high rate of durable local tumor control for small-sized malignant deposits. In STT, multidisciplinary management has a considerable impact on the prognosis. Desmoids, on the other hand, also called aggressive fibromatosis, are rare, locally aggressive, benign, non-metastasizing tumors of mesenchymal stem cell origin with a monoclonal proliferation representing less than 3% of all soft tissue tumors. Desmoids can occur anywhere in the body and in different connective tissues, including muscle, fascia, and aponeurosis, with a tendency towards local tumor recurrence. Systemic treatments and histological local therapies, as surgery, radiation therapy, are associated with a huge morbidity which is hardly acceptable in patients who are otherwise young and healthy in most of the cases. Moreover, the efficacy of those treatments is limited in many situations. Interventional radiology has emerged as a valuable alternative to treat these tumors. Desmoids are an ideal indication of percutaneous treatments given the morbidity and limited efficacy of other treatments and relapse after surgery. The ECT hardware required for the treatment of soft tissue tumors are, on the one hand, the generator provided by IGEA. The electrodes, they might have a fixed architecture with a linear shape or hexagonal shape and adjustable penetration depth, or freehand electrodes with different length, active tips, and diameters. What about the evidence? These are two studies on the effectivity of ECT in the treatment of soft tissue sarcomas. They could demonstrate a complete response of 100% in the first study with sarcomas with a median diameter of 4 centimeters. There was a progressive disease in none of the patients. And in the second study, a durable response of 80% with a 2 years local progression-free survival in tumors with a mean diameter of 4.7 centimeters. The evidence for in the treatment of desmoids with ECT is much less. We only have a few case reports. They could demonstrate that ECT is not only able to reduce the tumors, but also is effective in symptom relief after chemotherapy, like in this study that could demonstrate the pain score decreasing in the course of time. There's more evidence in the treatment of desmoids treated with cryoablation, with freezing. And in the study published by Schmitz and colleagues in AJR, complete response after cryoablation could be demonstrated that ranged in between 30 and 50%, and 1 year tumor control after cryotherapy was estimated to be 80%. In the following, I'm going to show you some own cases of soft tissue treatment with ECT. In this case, we treated a mix of fibroid, sarcoma, and on the right cervical area, we administrated the bleomycin via a microcatheter to achieve a better local toxicity, and were able to achieve partial tumor destruction after the first therapy. This image is performed 48 hours after the ECT therapy. This is a further case of sarcoma metastases On the left cervical part, we treated with a hexagonal electrode. These were deep-seated sarcoma metastases we treated with freehand electrodes, and again the imaging study 2 days after electrochemotherapy. This is a case of a desmoid treatment with ECT. We could demonstrate after 4 weeks a shrinking of the tumor with partial destruction of the desmoid tissue. And this was a case of a young girl of 11 years old with desmoid in the knee band, already 2 times treated with surgery with a repeated tumor relapse in the same location. And we were able to demonstrate a shrinking of the tumor, what resulted in significant pain relief and better mobility in the knee joint. Summing up, the role of ECT in the treatment of soft tissue tumors. ECT is a safe and effective treatment to achieve local tumor control in soft tissue sarcomas. This is already evidence-based. On the other hand, the effectiveness of ECT in the treatment of desmoids needs to be tested in multicenter studies beyond the existing case reports. ECT is not only the new kid on the block, but is also a gap filler and might become a game changer. Thank you very much for your attention.
Thank you, Attila. Now, can you hear us?
I can hear you. I hope you can hear me and see me too.
Okay, thank you. Now, any question for Dr. Attila, please?
Okay, I'm still waiting for the answer of my first question.
Yes, thank you.
I had to just to remind, it was about treating lesions, tumors in the liver, selection criteria regarding size and character of the lesion, like infiltrative lesions. So,
yes, thank you very much. This is the main topic, and the main issue is an excellent question. In treating different types of lesions in the liver, we have a lot of experience in terms of we are using radiofrequency, microwave, cryoablation, brachytherapy, and ECT. And surely ECT is one of the most appropriate techniques to focus on larger lesions and non-spheric lesions. And on lesions, they have very good vascularization. The better the vascularization of the lesions is, the better is the tumor control with electrochemotherapy. This is also one of the insights what we published last year. Definitively, ECT might be a troubleshooter and a technology we have to take to account in localizations, in challenging locations, in the immediate vicinity of central bile ducts, in the liver hilum, or major vessels. If these vessels are, for example, infiltrated, because ECT is able to perform a certain kind of skeleting the tumors from the collagenous structures. It's a little bit similar to brachytherapy, and the big challenging and the competitor of ECT is, from my point of view, the brachytherapy, because it's the second therapeutic option which is able to address non-spheric and large lesions. If you are thinking on using ECT in large lesions, it's mandatory to define subdomains to be able to preserve the plurality and the optimum distance in between and spacing in between of the electrodes.
Thank you very much. Any other questions?
Thanks, Professor Attila, for your
Thank you.
excellent talk and the excellent technique. And I am Dr. Baraki. I want to ask you about how you adjust your target size for a tumor, for example, 4 centimeter. You know that if we want to kill a tumor 4 centimeter, we should achieve 5 or more centimeter tumor to have tumor control, to produce safety margin. So by your technique, how you adjust your safety margin and how you adjust the total size of the tumor to kill relative to the original tumor?
Yes. Great question. Thank you very much. It's an expert question. Therefore, we are using the stereotechnic navigation system to be much more confident in defining the safety and security margin surrounding the tumor. And from our approach, the contrast-enhanced T1 weighted images with fat saturation and or the T2 weighted images are very appropriate to define this security margin and to be able to navigate precisely the electrodes into the appropriate positions. What is not as confidently possible to perform with CT guidance only.
So you are using CT mainly?
We are merging the MRI, the pre-interventional MRI images, and the CT scan, what we performed immediately before the intervention. We are matching them, and with the cascadation software. It's one of the brands I feel I'm very confident with, and then we are able to use for the navigation of the CT guided navigation of the electrodes. We are using the MR images because of the matching, and that's, from my point of view, it's a very good approach to be able to address the security margin surrounding the tumor. What in many cases, it's the diameter of the real diameter of the tumor is much larger than we can what we are assessing in CT.
Okay, thank you very much. Any question from the floor? Professor Ahmed Sami.
Just back to the liver, asking about pedunculated tumors. Is it okay for these kind of tumors? Pedunculated, exophytic.
Which kind of tumors, please? Sorry.
HCC, which is pedunculated with the pedicle coming out of the tumor.
HCC, CCC, and neuroendocrine are working excellently. And the same is true also for intermediate vascularized tumors like colorectal cancer. HCC, it's an ideal target for the ECT because of the hypervascularization. And surely we can adjust and assess much precisely the tumor margins that is possible in, for example, in colorectal cancer. Mets.
I mean, when the tumor is exophytic, when it's pedunculated out of the tumor, is it amenable for this kind of treatment?
If it's exophytic, you have to take to account all these non-spheric areas and to include in at least one subdomain of your treatment. We published also last year that the Kaplan-Meier curve in HCC, it's excellent. It's a horizontal line even in large HCCs. That means it's quite effective.
Okay. Any questions? Thank you, Dr. Attila, for your existence. Thank you for attendance with us. Thank you.
Thank you very much.